welcome back to my channel with a new video. This is the part 2 of the practice changing papers in nutrition in shock, which we left last time. And in this particular section, I'm going to embark upon the various studies, trials, guidelines starting from 2014 till date. So let us start with the topic. Coming to the calories trial way back in 2014, which actually focused on the impact on the critical care nutrition, and it actually had few signals about prioritizing the enteral nutrition early in course of the disease and avoiding early parenteral nutrition unless the enteral nutrition is contraindicated or if it is not tolerated. So this was the first kind of uh, the major trial conducted as regards the nutrition in critically ill patient. And coming to one particular shock or various types of shock, now talking about the cardiogenic shock, which we all know, which will have a unique nutritional challenges based on these three aspects of fluid overload, where we have to manage fluids very cautiously and administer them very judiciously. Impaired GI function, where we may have to consider parenteral nutrition, and of course there is a risk of sodium load, so we need to restrict the sodium intake. And this is the paper which I'm talking about from the critical care 2018, which talks about early enteral nutrition for cardiogenic shock or obstructive shock. So these are the two shocks requiring ECMO, and it was a nationwide inpatient database study. And here you could see the various vasopressors and the inotropes, including noradrenaline and vasopressin. And they concluded by saying that this particular shock requiring veno-arterial ECMO may be associated with lower mortality. So there was definite signals and some beneficial effects if you start with 2014 and then coming to 2018 with the cardiogenic and the obstructive types of shocks. Now this was a very famous Nutri-RIA 2 trial, came out in Lancet 2018, which discussed the enteral versus parenteral early nutrition in ventilated adult patients with shock, and it was a randomized controlled trial. And here again you could see that the vasopressor support in the form of noradrenaline, adrenaline, dobutamine, and this was the dose of noradrenaline 0.56 and 0.5, which is a reasonably high dose. And this was a category of infections which were looked upon in the form of VAP, bacteremias, CRBSIs, UTIs. And in conclusion, they said that our trial shows that the enteral route is not clinically superior over parenteral route, especially for the early start of nutritional support. And in fact, they have showed that there can be a potential risk of GI complications. Now let's see how it has unfolded and how was the change of the concepts over the period of time. So this was 2021 article with early enteral nutrition tolerance in patients again with cardiogenic shock requiring mechanical circulatory support. And these were the signs of GI intolerance, including the GRV of more than 250 ml, that is gastric residual volume, followed by aspiration, diarrhea, vomiting, abdominal distension, and intestinal ischemia. And these were the vasopressors in the form of noradrenaline. So in conclusion, they have said that early EN intolerance, which was associated with adverse prognosis, so they did not find a very good results with early EN in patients with cardiogenic shock. Then came the famous NutriVAD study, which was published in 2022. Here, the enteral nutrition in critical ill patients requiring vasoactive drugs were studied, and they concluded by saying that EN in this patient seems to be feasible, safe, and unrelated to serious complications. So here probably again in 2022 there was some signals towards early EN in the patients of shock, be it be a cardiogenic or for that matter the septic shock. And this was probably, I would say, a landmark kind of trial, the Nutria 3, again published in Lancet. This was in March 2023, and here low versus standard calorie and protein feeding, which was compared in a ventilated patient with shock. Again, it was a randomized controlled trial, and what needs to be remembered here is the low group received the calorie count or the calorie dose of 6 kilocalories per kg and proteins of only 0.2 to 0.4 grams per kg, which is reasonably low dose. A standard group received 25 kilocalories per kg and proteins of 1 to 1.3 grams per kg, and both the groups after 7 days were converted to 30 kilocalories per kg and 1.2 to 2 grams per kg after the 7 days. And you could see that these were the acute illnesses in ICU, so it was almost kind of a multi-organ or the multidisciplinary patients, and the predominant shock which was seen was sepsis and cardiac, and followed by others. So what you could see here, in both the low and the standard group, you could not see any statistical significance as far as the transfer of these patients from ICU to the wards. And this is the secondary analysis which showed that the 90-day mortality and the transfer of these patients again had no statistical significance, whereas time to invasive mechanical ventilatory days were shown to have a statistical significance of the p-value of 0.007, which was so this was the cutoff for the p-value. And here, as you could see, so this definitely showed some benefit in terms of weaning of the patients from mechanical ventilation. If you kind of see here, as far as the GI adverse effects are concerned, all of them would have statistically significant low GI side effects in the low group rather than the standard or a high group. So in conclusion, it was suggested that the restrictive group, which was a little bit superior to the standard calorie and protein group, so this was something which was probably very striking, and I would say this would definitely have some impact on the practice changing patterns of an intensivist. Only one thing which I want to kind of deliberate and make you understand, that the low group was reasonably quite a low group in terms of calories as well as protein. Here I would say, if the individualized practice, we may go up a bit on calories from say around 6 to 8 or 8 to 10 kilocalories to start with, and proteins from say 0.4, which has been suggested, to say about 0.8 to even 1 gram, I would say, and the patients in clinical practice would definitely tolerate these. So this was the ISPEN 2023 guideline, and which talks about early and progressive EN. And here what have they stressed is, after about 2 to 3 days of the initial admission of these patients in ICU, we need to actually start them on EN with the logic of opening up of the GI or the of the gut or the enteral route, as has been mentioned here, and having a very very kind of gradual approach of starting of the nutritional support from say around 20 to 50%, and then going up optimally beyond 50% after the third day. So the early enteral nutrition, as we have said, and protein intake, which they have stuck to around 1.3 grams per kg per day, which seems to be a very reasonable target. And as I said, this was 2023 ISPEN guideline. Where the patient is on vasopressor agent, of course they started with a low dose enteral nutrition, and of course they held the enteral nutrition for the patients who are actively resuscitated or unstable, and we'll come to what are the desirable vasopressor dosage which can be acceptable for these patients. So in the setting of a hemodynamic instability, hold EN until the patient is fully resuscitated, and of course consider initiation and reinitiation of EN with caution to the patients undergoing withdrawal of vasopressor support. So coming to 2024 ISPEN guideline, where they have clearly stated few gray areas, and I personally believe that yes, there are few points to for us to label whether which patient is hemodynamically completely stable or completely unstable, which are the patients who have these vasopressor dose which are acceptable, and there are few kind of numbers which has been postulated, and we'll come to that. So there were definite obscure definitions of controlled or uncontrolled hemodynamics. There were definite unvalidated vasopressor dose equivalent scoring systems, and there was evidence of early EN, especially within 48 hours in shock, where they need vasopressors, and of course the beneficial effects of early enteral nutrition even with multiple vasopressors were stated. So this is what I meant. So whatever the stable doses of vasopressors in smaller or moderate doses were acceptable with a target mean pressures of about 70, which seems to be a little safer threshold for them to start with the enteral nutrition. NOMI and NOBN should be kept in mind, and EN should not be initiated in this patient, and how much is the safe dose and the time is probably is all based on the individualized approach. And these are the doses of noradrenaline. So probably any dose which is less than 0.3 microgram per kg per minute of noradrenaline, and any dose which is probably equivalent to 0.023 units per minute of vasopressin is something which is acceptable as far as the ISPEN 2024 guidelines are concerned. This was one of the largest meta-analysis which I came across. It was published in Nutrients in May 2024, and it took records from Medline, Embase and Central with the records from SCCM and ESICM, and they found that the low quality evidence actually suggested for the patients receiving early enteral nutrition could require fewer days of mechanical ventilation and may show lower SOFA scores. Also, there could be an increase in the incidence of diarrhea episodes, but it can be reasonably safe and effective. So this was probably the last, the very, very recent message as far as a meta-analysis is concerned, which showed that definitely early enteral nutrition in the form of an individualized approach with low dose can have an impact on the overall morbidity and mortality of these patients. So I would probably, this is my last but one slide, and I would say that these are the take-in messages for my talk. We should be aware of the catabolic and the anabolic phases which are involved in the sepsis patients. There has to be an individualized approach. The EN which is beneficial, but we should also be aware of the deleterious effects and the dynamism involved in the same. Of course, there are obscure definitions of hemodynamic stability and instability. Combination of vasopressors and inotropes are more deleterious to the gut. Noradrenaline acceptable dose of less than 0.3 microgram per kg per minute, and vasopressin of less than 0.023 units per minute. EN should always be preferred, and preferably in the after the first 3 days we need to have something like an open enteral route approach with delivery of about 20 to 50% of the target. Parenteral nutrition only if the enteral nutrition is not tolerated, and low dose strategy is probably something which is acceptable by the patients, but they have the problems of conflicting results and controversies. So on the basis of that, I would probably say that we need more studies, more data and more research. And yes, there are future directions which are ongoing research on the personalized nutrition, on the novel biomarkers related to the nutrition and the monitoring of the nutritional status, and of course the long-term outcomes which needs to be kind of monitored. So that's all for now. Thank you very much for listening. Take care. Bye bye.